Hi, my name is Erika Arvelo, and I go to the Lake Erie College of Osteopathic Medicine in Bradenton, Florida. Today, I'm going to be presenting on swallow syncope. Imagine if every time you had a sandwich, you passed out. Now that would be inconvenient. So is the case for our 55-year-old patient that came in through the ER. He was preparing his morning sandwich when he had one bite and became lightheaded. He apparently fainted and collapsed on the floor. He woke up on his own and called 911 that brought him to the hospital. The patient has a significant past medical history of MI, heart stent, and coronary artery disease and hypertension. At the ED, he has a blood pressure 78/51, and we immediately were concerned for a cardiac cause. So we did an EKG, drew troponins. The patient then had a chest x-ray, CTA, chest, abdomen, and pelvis. And all of this workup was normal. It was unremarkable. We started the patient on IV fluids, and he continued to be hypotensive, which led to him being admitted. During the admission, he had a continued workup, such as carotid massage, an echo, cardiac cath, EEG, CT brain, and really we were at a loss of what could be going on. So then on day 2, the patient was eating his sandwich in the morning when he got up and nearly fainted. He did get dizzy, and his systolic blood pressure dropped to the 60s, but he did not lose consciousness. IV fluids at that time did improve his blood pressure to the systolics of in the 80s. At that point, we were curious about the relationship between his breakfast and the episodes of syncope. So we did orthostatics and evaluated with the barium swallow and an esophagram that were still not conclusive. So on day 3, the patient had his breakfast, and we noticed a sinus bradycardia of 49 beats per minute. But the patient was able to eat soft solids, such as fruit cups, without syncopizing. So at this time, he was discharged with a 2-week event monitor. The diagnosis of swallow syncope is a rare one. It has to do with the neurally mediated reflex syncope of the vasovagal syncope umbrella. It is believed to be due to a superior laryngeal nerve and carotid body activation that leads to the vagus nerve carrying the signal to the nucleus tractus solitarius, and then an efferent limb of the vagus nerve acts on the cardiac electrical conduction system to slow down the system and lead to syncope. While it is a rare type of syncope, it is still a relevant one. You have to keep all those vasovagal syncopes in mind when a patient comes in. It is a diagnosis of exclusion through extensive workup and assessing for a temporal relationship between eating certain foods and the syncope episodes. You can arrive at this conclusion. It is commonly seen in patients with esophageal or cardiac abnormalities. We believe the previous MI may be a cause for this event, because there was no esophagus dysfunction noted during the examination and during the workup. The treatment for swallow syncope includes swallow modification, which can be done with speech therapy, which this patient did receive, and you educate the patient on the triggers, which is actually bulky foods such as the sandwiches the patient is having, and hot or cold foods, and carbonated beverages as well. So the patient is instructed to avoid this as much as possible. And a pacemaker may be useful if a patient is continuously syncopizing, which is why this patient was discharged on a 2-week event monitor to be followed up by cardiology. So we'll be interested to see if these episodes of bradycardia and parasympathetic response continue and require a pacemaker placement. This case is very important to remind you of needing a broad differential for syncope and of keeping your mind open when the answer is not readily available. And I was glad to meet this patient, and I'm happy to present to you guys today. Thank you for listening.